Hello, welcome to this Real Talk, Bleed Management and Antidotes. The vitamin K antagonists, and warfarin in particular, were introduced more than 60 years ago and have had a dramatic impact on clinical medicine. Initially used for the outpatient treatment of deep vein thrombosis and pulmonary embolism, they ushered in a new era of mechanical heart valves used to treat valvular heart disease, changing lives for thousands, for hundreds of thousands of people around the globe. In the setting of atrial fibrillation, a disease that affects 1 to 2% of the population, more than 400,000 Canadians, warfarin is extremely effective to protect people against stroke, reducing the risk of stroke by about 2/3 and reducing mortality by about 1/4. But warfarin has important limitations. It's inconvenient to use because it has an unpredictable anticoagulant effect. It is interfered with by food, by alcohol, and by many other drugs, and it's associated with a high risk of bleeding. The result, consistent underutilization of anticoagulants for stroke prevention in atrial fibrillation. Clearly, there is a pressing need for alternatives to warfarin. The past decade has seen this unmet need met with the introduction of a series of non-vitamin K antagonist oral anticoagulants, which are at least as effective as warfarin and are even safer without having the inconvenience of requiring routine monitoring. The safety advantage, no less than a 1 in 6 or a 1 in 7 reduction in major bleeding, and reduce the risk of intracranial bleeding, the most feared complication of anticoagulant therapy, by 1/3 to 2/3. One could be forgiven for anticipating that with the introduction of the NOACs, we would have seen a closing of the gap, the unmet need of the untreated patient with atrial fibrillation. But sadly, clinicians now faced with an unprecedented range of tools to protect patients against stroke are feared of the risks and consequences of bleeding. As depicted in the cartoon, the crocodile before them, the threat of stroke, has spurred them on to consider the use of anticoagulants. But now, with highly effective treatments, they're worried about the shark. They have a visceral fear for bleeding. We think of stroke as acts of God, but when a patient bleeds on an anticoagulant, we feel personally responsible. The consequence of the fear of bleeding is that we undertreat our patients. In these data from the Garfield registry, we see over a period of the past 5 to 6 years, a steady but minor uptake in the overall use of anticoagulants. We see somewhat of a decline in the use of warfarin and an increase in the use of NOACs, but 1 in 3 patients is still undertreated. A large number of people still relatively unprotected or completely unprotected against the ravages of stroke. What can we do about improving the uptake of anticoagulants in atrial fibrillation? One of the key challenges is overcoming the fear of bleeding. We must start by considering that anticoagulants in general have a large benefit despite being associated with the risk of bleeding. And we must consider that the NOACs are safer with lower case fatalities after bleeding than warfarin. But clinicians need further reassurance, and in particular, there has been an overwhelming outcry in relation to the need for a specific reversal agent. What's new? We now have that very agent, idiucizumab, a specific reversal agent for dabigatran. now approved for use in the United States, in Europe, and here in Canada, idesicimab, a humanized monoclonal antibody, rapidly and completely reverses dabigatran. And the effect after a single 5-gram bolus of idesicimab is sustained for at least 12 hours in almost all patients. Idesicimab is very simple to use. It comes out of the fridge in a pre-filled vial. It's connected simply to an intravenous infusion set and is administered over a period of 3 to 5 minutes. At the completion of infusion of idesicimab, dabigatran is completely reversed in almost all patients. The evidence for this has been published in the New England Journal of Medicine in 2015. When measured by specific coagulation tests, both patients with urgent bleeding on dabigatran, with serious bleeding on dabigatran, as well as patients requiring urgent surgery on dabigatran, had immediate, complete, and sustained reversal of anticoagulation. What about the other NOACs that have been introduced into practice? Dexenalpha is a factor 10 decoy that has been developed as a reversal agent for the factor 10A inhibitors. This agent is still 1 to 2 years away. It is a coagulation factor that has been modified. It works unlike idesicimab. It works in a competitive manner. It has a short half-life, and its effect wears off rapidly. As a consequence, it must be given as a bolus followed by a continuous infusion in order to sustain the reversal of anticoagulation. Where can you find more information about bleed management and the reversal of the NOACs and warfarin? The European Society of Cardiology has published a bleeding management algorithm, and other international societies have done the same. Here in Canada, we have our own Thrombosis Canada website, which is a rich repository of resources for clinicians. Clinical guides abound on this website, very practical and simple to use, as well as tools that you can download through an app onto your mobile device or iPhone. The future of anticoagulant therapy is here. Years ago, we were restricted to one oral anticoagulant class, the vitamin K antagonists. Today, we have multiple oral anticoagulants available for clinical use. The NOACs are at least as effective, are safer, are more convenient. And today, in Canada, dabigatran ataxilate can be immediately, completely, and in a sustainable way reversed with idesicimab. Never before have we had the opportunity to achieve complete coagulation control for our patients and thereby being in a position to treat as many patients with atrial fibrillation for stroke prevention. Thank you for your attention.